Hi, everyone. Welcome to today's Student-Led Journal Club seminar series. My name is Anne-Marie Hayes, and I'm a research associate on the Joplin campus of KCU. Today, I will be introducing our speaker, student Dr. Sapatwalla. He's going to be talking to us about value-based care, a unique model for a large-scale health system. So, to introduce our speaker, student Dr. Sapatwalla is a third-year medical student at Kansas City University. He is from Flower Mound, Texas, and has completed a degree in business administration at Austin College. He is passionate about public health, medical education, and healthcare administration. He plans to specialize in trauma or minimally invasive surgery. In his free time, he likes to play basketball, chess, and enjoys traveling. So without further ado, the floor is yours.
Thank you so much, Anne-Marie. Thank you everyone for having me here today. My name is Taher Sapatwalla, third-year medical student. And today my presentation will be over value-based care, going over a unique model for a large-scale health system. And so a little bit about the outline. We'll go over the problem that we have from the transition to value-based care, specifically comparing it to fee-for-service-based care. Then we'll go over a few literature review articles. And then from there, we'll go into the analysis of the article for today and then a conclusion statement. So when people think of healthcare in the United States, if you ask the normal patient, most of the time they may say that it's a fee-for-service based model. That what that is that a doctor or a physician prescribes the amount of services or orders, and per order they have a pay that comes from the payer. And so it's based on however many services that are ordered for the patient. And that's the basis of fee-for-service. And a lot of the models that have been used traditionally in healthcare have been more, in a sense, physician-centered, in that it's based on the physician's performance or what the physician prescribes or how much costs that are decreased that are measured for the payment model for the physician. However, over the last decade or two, there has been a transforming shift of healthcare towards value-based care. And in a nutshell, value-based care is having it move from the physician-oriented side to having it patient-oriented. So all the services, all the details that surround the patient's complaint, not just what they present to at a hospital or a clinic, but the overall well-being of the patient, it measures the outcome. So has the outcome of where the patient's health, where we want it to be, has that been met? And that's the whole emphasis of value-based care. And so I just listed here on the slide 4 different examples of the comparisons between both. And so in the payment system, like I said earlier, fee for services, you get paid based on the number of services. So the more services that are prescribed or ordered by a physician, the more pay that the physician receives. And again, there's also an argument that a physician could tend to overprescribe services that may be detrimental to the patient or not even needed by the patient, which the cost for the patient cannot be met. Whereas in value-based care, it's about quality, and not only just quality of care services. So if, for example, a patient needed the necessary amount of services, that's just part of the guidelines of the health, they also need to consider the cost that they're delivering. So value means that you deliver the quality of services while minimizing the cost. And so that's the whole importance of quality care and having it patient-centered. The price of care, like I mentioned, in fee-for-service, by overprescribing, there can be a redundancy of care that another provider could also provide the same exact thing at times, or maybe have an unnecessary order. Whereas in value-based care, it's about lowering the cost, therefore increasing the value. Patient satisfaction over time tends to be higher in value-based care because the long-term results lead to lower admission rates, longer term health for patients, and overall mortality rates decrease. So overall, the patient satisfaction is therefore higher. And then the long-term care fee-for-service does not have any incentive to overprescribe or underprescribe. Whereas in value-based care, physicians are incentivized based on the amount of care that so if they serve a population and that population ends up increasing their outcomes and having better outcomes for patients, then physicians are also incentivized to get monetary payments, while at the same time will also have their penalties. So this is just an example of a dentistry workflow. And as you can see on the right of the diagram, the value-based care kind of moves its focus onto the patient and not just only what they present for, but all aspects of it. So if they look at a patient that maybe is disabled or has a little bit of healthcare literacy problem or things like that, they have these prevention methods such as telemedicine, teledentistry, minimally invasive techniques. And at the same time, there's a lot of technology that is integrated into the electronic medical records that focus on linking the quality to care. So they have these gap systems where it's almost like a checklist-based system that staff uses to see have the gaps been met by a patient. And just a quick definition of what a gap is. A healthcare gap is something where the care that is provided to a patient and the quality guideline that is met, if there's a discrepancy in that, that means that the care that you provide is not up to the quality standard, that's a gap. So an example would be when somebody turns 45 years old and they're due for a colonoscopy screen, but they have not received their colonoscopy screen, that's a gap. Or when a woman turns 21 years old and is supposed to receive a pap smear and she does not receive that, that's a gap as well. And so going more into the literature review. So this first article is a group of physicians based in Champaign, Illinois, that analyzed the quality metrics of a hospital system there. And so they came to two conclusions based on the value-based care that they gave. They came to two conclusions. So the first thing is there has to be an overwhelming amount of professionalism by the physicians and healthcare providers. What I mean by that is when you move from a value-based care to a fee-for-service or whatever the previous model was, there is a sudden way more responsibility by the physician and a lot more effort that is needed and a lot more collaboration that is needed. And to understand what the patient exactly needs takes a lot of professionalism, such as understanding their cultural backgrounds of the patient. If they're, for example, a Hispanic speaking population, then they would have to have guidelines as such and understand their cultural backgrounds for such, and then adapting their care too. Also, like social determinants of health. So if a patient is receiving insulin, for example, and they don't have access to a fridge to keep their medicines cold, or health literacy. So those are things that are outside of the presenting problem that are all meant for patient-centered. And all of these outcomes, when taken into account, can overall decrease the readmission and mortality, and it solves a lot more problems. So that professionalism has to be there by the provider to understand that and to collaborate with the right people. And then the second thing is through the collaboration that I mentioned, that there's a shift in performance-based to organizational-based metrics. So now there is suddenly a lot more physicians, a lot more care team members involved in taking care of a patient, rather than just one physician prescribing what they need to prescribe, then the second physician, and so on. And so it prevents the fragmented rewards. And so the entire hospital is incentivized to work together. And that team-based model has like multiple factors to influence the results. So for example, a patient that has diabetes that needs to meet the quality guidelines of a 6.5% A1C may also have a comorbid psychiatric disability. So they have psychiatric services for that. They'll also have social services for any problems with barriers to health, and etc. And so overall, by solving all these problems, it could contribute to the main problem of diabetes as a whole. And so by working together to have a comprehensive care is a way of closing the gaps in healthcare. And so this second review article is a unique system of a complete care at Kaiser Permanente. So this is a large-scale health system based in California, Colorado, and Hawaii. They serve a wide variety of the population over there. And so they have a model for value-based care that they have a proactive office encounter. So basically their EMR system is very technologically advanced in that they have a wide array of gaps that are detected by the EMR system so that the staff can recognize that and pre-encounter, office encounter, and post-encounter, make sure to check those gaps off so that patients are all met with their screenings. And so on the diagram on the right here, you can see that the pre-encounter, there's a proactive identification. They identify patients that have missing labs or screenings. They also contact patients to make profiles at the KP Health so that you can transition and facilitate the process upon arriving. Then the actual office encounter for identifying red flags, vital signs, documentation, and then the post-encounter follow-up where there's an aftercare visit summary, instructions, health ed materials, follow-up appointment. And that's the important thing, is that having a follow-up that is in charge by the provider shifts the point of care away from the patient and onto the provider so that appointments can be met and fulfilled that way. And so they also have this system is a good way of detecting patients that are out of network and those that have not attended the clinic for a very long time and detect a lot of those gaps. So it's through a very powerful EMR system that they have. This literature review is about a rural Kentucky case. And I found this case interesting because it was a small hospital that had a very like new and radical approach to value-based care. And so what they did is they said, you know, there's a lot of hospital systems, there's a lot of methods and a lot of ways you can implement value-based care, but a way to be successful is creating a climate for change. And so they created an 8-step 3-tenant value care system. And the first tenant was all about creating the climate for change. And that was the highest priority by the hospital. And so if you involve the CEO of the hospital, the leaders of every department, your quality care team, all of them are involved in this project. And not only that, but they make it a priority by the hospital that no other thing that is more important than this, then that climate for change is created. And now physicians and providers and staff are all understanding the seriousness of it, and then they'll have the mentality that they cannot let this fail. So it has a sense of urgency, and they have a strong vision. And through that strong vision is how the motivation creates itself. And so after they create the climate of change, they make sure to go through a lot of efforts to educate physicians. They had a lot of meetings. They had a lot of ways of finding actionable ways to close the gaps. And they made their efforts very proactive. And so through that, they also enabled the whole organization by empowering not only just providers and physicians, but nurses, other staff. So for example, nurses would allow nurses to give immunizations according to the gaps mentioned on their EMR system. And then lastly, once they started to reap the results from that, they built the consistency by rewarding those that deserve the rewards for their healthcare, and they would make sure that their results were on display so that everybody knew that there was progress being made, and the motivation would only self-build on itself. So this case was very interesting in that they created a very strong climate, and the climate itself was what took over the entire movement. And then this literature review is about accountable care measure sets. And so we know that there's a payer that identifies the gaps. They show that to the provider. The provider then adjusts their clinical guidelines to meet those gaps, and then their performance is how they're paid. So that model is understood. But this literature went into what the measuring set actually entailed. And so there was this group of doctors found 2 accountable care organizations and then 20 common clinical conditions, as you can see in the diagram over here. And through their analysis, they said that the outcome measures, the process measures, the measures that doctors are evaluated on before receiving their reimbursement, a lot of those measure sets, there's a discrepancy between what the quality guidelines by the payer is and what the clinical guidelines by the doctor are. And so that discrepancy can lead to a discrepancy in the gap, less likely for the recommendation for the quality improvement to be met, and also a reimbursement by the provider that is lost on. So this is just an article that says that the measuring set itself needs to be evaluated and recommended. And you can see right here that multiple sclerosis, all the way here, there was no outcome measures and no process measures. So there was no way of evaluating what was clinically relevant or what clinically improved in a multiple sclerosis patient. So this is just showing an example that the measuring set could be improved on. And then this literature review was the provider perspective. And so this article knew that, all right, there's many different value-based care. It's also a relatively newer model system that's being implemented in healthcare. And they wanted to know what was the actual adherence by providers. So were providers actually taking that quality data that was provided by the payer and implementing on it? And so this study took 118 healthcare groups, and 55 of them were interviewed. And you can see on the diagram on the right, only 18 of those 55 clinical groups were admitting that they used the quality reports that insurance provided. And so upon further interviewing, they found out that it was mainly because the information was not actionable. And as I mentioned in the last report, that there is a discrepancy in the measuring that the quality care guidelines provided by the payers are and that of what the clinical guidelines are in the actual practice. And that just takes a lot of years of experience being at the practice to know what their patient demographics are, what their population is, and what they want. And so the first thing and the main thing was that it was not actionable gaps. And the second thing is there was a lot of information overload. And so that the quality metrics that were provided takes a lot of time to look through and a lot of time to make it actionable results. And physicians and providers usually don't have that time. And so common solutions for that is having that integrated into the EMR system, as I mentioned in Kaiser Permanente, how they had a very strong support tool to allow the gaps to be pre-identified by the EMR. They can also hire administration staff to facilitate that process. And then lastly, and most importantly, the payer-provider collaboration. So knowing that the gaps that the measuring set that the payer provides to what the provider can make actionable has to be as equal as possible so that the gaps are actually completed. So that collaboration is important. So that brings us to our analysis. Student Dr. Nicola Duong and her team wrote a paper on the analysis of value-based pay-for-performance gaps in the care delivery framework for a large care health system. So a little bit of an intro on this paper is that, as you've seen from the literature review, that healthcare is transforming from a fee-for-service to a value-driven patient-centered model. And so this article analyzed Northwell Health. It's a large integrated healthcare system in New York, and it has a very unique 7-step model for providing value-driven care. And the quality standards were given by HEDIS, which is Healthcare Effectiveness Data and Information Set, which is one of the strongest quality improvement tools used in a lot of healthcare systems today. And the incentives that the providers were evaluated on was based on the Centers of Medicare and Medicaid Services star rating. And so it's a little bit on what that is that they have these metrics that are evaluated, and the hospitals then graded out of 5 stars, with 5 being the strongest. And these are the weighted factors that they use. And as you can see, the majority are based on mortality rate, the safety and quality of care, the readmission rate by the patient, and the patient's experience overall. And so here's a 7-step process, and it's a very unique methodology that has worked wonders for them. And I'm going to go through each step in just a second. So step 1. So the payer identifies the gaps. So there's the payers. It could be Aetna, it could be healthcare, Health First, and then they provide the Northwell Health provides the data and communicates the transfer to the payers of what the value-based contracts are and what the gaps are. And so that's the payer then identifies the missing services. But before those payers can go directly to the providers, in step 2, there's a validation step. And that's what makes this process unique, is that there's a gaps in care team. So the gaps in care team takes the data from the payers and then confirms any additional gaps that have not been met through very smart tools such as CORE, and I'll get to that in a second. It also makes sure that the gaps are following HEDIS guidelines and are also applicable to what the physicians can also meet. So it's basically taking away any measurement discrepancies from the payer into the provider. And that's a very important step for them. And so this is a table showing what the HEDIS guidelines are. And so these are just common screenings that are used. And again, I said it's one of the most strongest quality improvement tools. And so you can see here, adult services, cancer screening, diabetes care, and pediatric services are all included. And then prioritization. So then step 3 is that, okay, so GIC team took the payers information, they integrated it and included more gaps that were not included from using other smart tools. And then prioritization is that it focuses on practices for greater opportunity, with the greatest opportunity, So that means they targeted practices that had patients that never showed up to the clinic in greater than 18 months, so that they were more than likely to be having a healthcare gap and missing their care. And so they not only had the information and just sent it to each and every provider, they prioritized which providers needed the most help, and by helping them, the star ratings could also improve as a whole better. So they had a step-by-step prioritization. And then from there, once they prioritized which health groups they wanted to target, then they distributed to the key partners. And this step is also very important because it becomes very personable whenever the gaps in care team understands what the clinical guidelines of an individual practice is, and they adjust the measuring steps so that the payer, like what the payers want and what the patients want as well, they make sure that it's on the same page so that the providers can actually make those gaps actionable. And so they build those relationships with the clinical administrative leaders in the targeted practices so that they can all come to an agreement and be on the same page for that. And then lastly, once the physicians have made it into actionable causes in their healthcare groups, then they start to outreach to patient. And so tool that the EMR system uses here is called SharePoint, and it's a very powerful tool that allows a greater outreach to patients that are in network and out of network. And so that outreach to patients, and it coordinates delivery of missing services, appointments, it shifts the point of care to the provider, a lot of that stuff. And so it's a very strong, important tool. And knowing how to identify that by having a strong prioritization and validation step. And so once the gaps have been starting to cover, there's a measurement system that is also done by the GIC team. And so they measure the progress in the closure of the gaps in care. And then the analytics step. And so once all the patient outcomes have been measured, the gaps in care team then analyzes the data, and then they review their performance of the practice. Did they prioritize the right places? Did the outcomes, were they sufficiently met? Is there any adjustment that I need to make in the strategy? Any other gaps that I was missing? And through that, they reanalyze the process and then ask for the additional information from Northwell Health, and then starts the process over again. And so the results in this paper is that 57,000 gaps were met amongst 4 payers, and Health First was the largest at 32,000. And you can see in the diagram on the bottom that 32,000 was identified originally by the payer, and then the smart tools that were used by the gaps in care team additionally that were called AEHR and Core Lab additionally identified over 7% more of the 57,000. And the coverage and the distribution of the outreach lists were incredible thanks to SharePoint, and the strong relationship between the payers, providers, and the patients, so the gaps in care kind of acting as that messenger between both of those parties allowed for a strong, comprehensive way of making those gaps actionable. And once they knew that that was a very comprehensive method, it allowed scale integration. And that's important because Northwell Health is a very large, one of the largest in New York. And so it serves over 12 million people. And to have that size of gaps to be covered, you need to have something that can be scalable and something that's successful. And that's something, this is a comprehensive way of showing that it has scale. And just more on the results is that Northwell Health GIC frameworks successfully distributed 63% of the identified gaps. And because of that, the long-term outcome is that the overall CMS star ratings improved. And so you can see that the benchmark was 3.5, and in hospital number 4, which was the Northwell Health Hospital, which they used to analyze, increased their benchmark rating. And so the whole takeaway is that from what we analyzed is that now that we see this whole movement towards patient care, there's a lot more effort involved. The transition has been a little bit at its pace, but we can see that through different models that have been creative in serving the patient, that there's many different ways about going about value-based care. And so being comprehensive is the first step, making sure that the right gaps, the number of gaps, and the gaps that can be actionable are met, and having that process. And so in this example, the GIC team was an example. So the second thing is the ability to outreach and engage the patient. And so once you have those gaps, being able to shift that point of care from the patient to yourself and saying, all right, we will take care of everything else outside of your complaints so that the overall value of care is served to the patients. And so an example of that tool will be SharePoint, which is also in this. And so there's other tools that have been used in the EMR systems as of late. And the last thing and the most important is the collaboration between healthcare leaders. And so having the right team and having the right motivation for change can bring about wonders in a value-based care system. And it has to take a collective effort, because now it's shifting to a team-based model. So one person out of the team, if they're not meeting their standard of care, can ruin the entire hospital rating. So everybody is involved, everybody has a say, everybody's important. And so that collaboration to meet the patient's care is starting to take place in value-based care. And through that, it serves the patient better long-term health, from readmission to mortality to their overall long-term health and all of that. And the acknowledgements, I thank student Dr. Nicolette Duong for her analysis, Kansas City University, and Marie for having the spot for me. And with that, I'll take any questions. Thank you very much.
Awesome. Thank you so much, student Dr. Sapatwalla. This was great. You did an amazing job walking through everything, and your visuals were super clear, easy to understand. Really quick, before I forget, actually, student Dr. Nicolette Duong is our presenter next week. It's not the same topic, so it's a little different. Anyway, I just thought that was so funny. You're the perfect segue to our presentation next week.
I know. She was very helpful with this and helping me understand, analyze the paper. We had a lot of discussions over it, and we both had the same interests over it. So that's why we worked well together.
Awesome. Yeah. Well, as you were saying, if you have any questions, feel free to either raise your hand in Zoom, or if you can't talk, you can put them in the chat and I will read them. It looks like Dr. Johnston has a question.
Thanks,
Yes,
Anne-Marie. Taher, outstanding.
Thank you very much, Dr.
To
Johnson.
my knowledge, is one of the first presentations relevant to the whole healthcare system. And the way you have simplified it in your presentation has enhanced some easy learning in the process. I'm going to jump to the very end, but I'd like for you to go back with me on this presentation. Yes. You're absolutely right. It's going to take is the chemistry right for the players that want to be involved in this system, and the motivation for change is not only focused around quality of patient care, but it's also driven, as you well know, by the almighty dollar. And there's a common theme that the quality of care has always been, let's say, the main goal, the main outcome. And with that is, what do you have to do to change to get that quality of care? And there's some things there that I'd like for you to at least explain and see where we're at in terms of, let's say you go into a hospital and you get taken care of and you spend, let's say, 5 days. And then there's routine post-care management and follow-up, and eventually to some long-term care. And my question to you is, one, do you have any room for explanation of benefits, implying you're with X insurance company, health insurance company, and once you get that major bill from the hospital, what does a patient actually owe? Meaning, you may get a hospital bill for $5,000, but the provider and the payer, insurance company, have agreed to, these are the rates we're going to pay you by, or the hospital, that is, these are the rates we're going to reimburse you on. So does the patient in both systems get an explanation of benefits? Meaning, how much do they really owe? That's my first question.
Dr. Johnson, thank you so much for your question. And so I just wanted to make it clear so that the value-based care, when it shifts towards the patient, there may be factors out of a patient that were not really addressed at the clinic or the hospital that they show. And so, as I mentioned in the diabetes example earlier, what if there was a comorbid disease that the patient held that was also responsible for the blood sugars? There's a lot of other purchases that may have to be made by the provider that, although would maybe increase the overall cost of services, would over the long run cause an increase in health in the patient. And now that's a very hard pill to swallow, because for value-based care, which is why the transition has been very slow, is because it's a lot of initial investment period. And the research article that was done by the Kentucky Care-Based System mentioned that the CEO himself said that it took over 2 to 3 years for the change to happen. And it was very hard to keep people motivated. It was a lot of investment period at first, and some providers were wondering why we didn't stick to how we did it before. But this is something that you see the long-term benefits. It's a delayed gratification on it. And so to answer your question, what the patient is responsible for, it varies. There's a lot of factors behind it, and it's a new system that is adaptable and is going to be slow because there's a lot of opinions at it, and there's a lot of ongoing research about it as well.
Yeah.
Hope that
I appreciate that answer, but I do want to say that patients are entitled to get a true explanation of benefits regarding this is exactly how much I know, because they'll get a bill for $5,000 and they may not have to pay all of that. So that's the practicality of when they're billed of this is how much it's going to come out of my pocket. And that's what basically through negotiations, the doctor has agreed for that service to be a reimbursed X number of dollars. So I do think that hopefully there'll still be some EOB in either system. There is now, but if we transition, we're transitioning over to value-based, it's got to have the same implications to the patient. This is the amount of money that you owe for the service that was provided. So that's my commentary on that. Then the other question to you is, what's the data relevant to, we're talking about quality outcomes, and with that is satisfaction on both sides. What's the quality of satisfaction of the docs with this VBC system versus what you got already?
It's a very interesting question, Dr. Johnson. And that's what kind of influenced me to have the research article on physician adherence to, because as I was saying, it's a very new model. And so I didn't expect the change to be implemented immediately. I don't exactly have research on what their satisfaction rates are, but I can infer that based on only in this example, it is a smaller, the limitations are that it is directed at a specific healthcare network. It may not have the broadest of population demographics. However, by seeing that only 20% to 30% of the providers actually utilized it, there's a lot of data that has been mentioned that there's a mixed methods where they're having a fee-for-service model along with the value-based care. So there's a lot of, it's not going to be fully 100% because I feel like that effort that is made by the provider, it can be overwhelming, and there has to be ways where there's a common ground for the gaps to be appropriately met and something that can be actually done and beneficial to the provider. And so this literature kind of gave me more insight that, okay,
you're right,
that there's not a lot of adherence, because on paper it sounds good. Oh, value-based care, we're saving money, the patient feels better over time, less readmission, less money overall, like we're doing a good thing as healthcare. It sounds great on paper, but why is there only 20% of providers actually adhering to it?
That's right.
The question of what you said.
And then when you show that slide of re-hospitalizations, as you well know, it's the acuity of the care that generates often, and chronicity of the problem. The comorbidities are cumulative, and subsequent readmissions are often a result of an exacerbation of any one of those comorbidities. So in short, sometimes the re-hospitalization, I think, is treated a little bit from a monetary perspective unfairly, and the doc is penalized for it, meaning they keep coming back too often on, let's say, my service, and they don't come back as often on your service because it may be an acuity of chronicity of comorbidities. Does that make sense?
It definitely makes sense. I understand what you're saying. And that's something that could be adjusted for in the payer's quality guideline, that if there is a disease that you are to expect almost acute on chronic exacerbation of anything, that they should have that accounted for by the payer whenever the guidelines are being met. So that
Yeah, and that's going to happen. That's going to occur with frequency as the patient ages and the disease processes accumulate or
Right.
worsen. Thank you again. Excellent explanations. Great presentation, and nice job.
Thank you so much, Dr. Johnson. I appreciate that.
Dr. Wolf, do you have a question?
Yeah, I also enjoyed this. So let me say up front that this is the type of thing that I would like to see, but similar to what Dr. Johnson said, I mean, it seems to me that there's a lot of hurdles that need to be overcome. So you mentioned like the assessment of how well they were doing, and I've seen situations where docs were graded based on how well they followed an algorithm, like for treating hypertension, that you did this and you followed that algorithm and that was great. And so you're treating all people the same rather than actually treating people as individuals, potentially in need of individualized care. That was just one thing that I'll throw out there. But so I've got a series of sticky notes here, and I probably am not going to say this well, but you were talking about evidence of benefit, or where is the evidence of benefit? I mean, how much are we seeing an increase in life expectancy at lower costs with patient willingness to actually participate in all of this stuff? Because being from rural Wisconsin myself, people generally don't, in the rural areas, don't like going to the doc. And when you're a doc here now and you're calling the patient in because there's this gap and that gap and the other gap, all of a sudden it seems like the docs are trying to rule a roost, potentially, where the patient doesn't have the freedom that they desire. I mean, we saw what happened with COVID, where people were refusing to take vaccines or whatever. They were refusing to engage in the manner that we would like to have seen them engage. So do you have any thoughts along those lines?
Right. So thank you, Dr. Wolf. Good question. I want to take us back to this review article. There's one more piece of information that was amongst the 55 healthcare groups that were interviewed. There's one more piece of information that I did not mention, that when they said that the information was not actionable, one physician quoted that it's not fair for the same guidelines to be applicable for every single provider group. For example, if a colonoscopy guideline has to be met every 5 to 10 years for a patient for the population that they serve, but they don't really account into the population demographics, like you mentioned, based on people that don't like to go to the doctor or don't have health insurance, cannot meet their deductible. Why would anybody, the physician quoted, why would my patient pay $2,000 for the deductible for a colonoscopy? They will just not show up anymore. But I have to be penalized for something that my population could not, come meet to terms, even though I'm doing what I can to follow the guidelines. So, like I said, there's a lot of ongoing research on it. There's a lot of studies that have detected, what's the practicality of what the patient can also meet as well. And so that also ties into the measurement set, that what's the clinical guideline and what the payer's guideline is. But you make a very good point that, understanding your population, understanding what kind of patients will actually come for something. If I just start reaching out to them, get your immunization, get your colonoscopy done. Another thing could be I would argue is health literacy. Maybe by educating my patients that by receiving the colonoscopy, receiving your immunization, it could prevent you from coming back to the doctor later on, because you can avoid a potential colon cancer because you have a family history, or it could protect you from a virus. Things like that. I think having education so that patients are aware and they can be reasoned into coming. So there's a lot of ongoing research about that, but that's a good question you brought up, Dr. Wolf.
I had one other along those same lines. So you were talking about the team approach. Well, when you have a team approach to things, then you get team bills as well. So it's multiple people coding, and it seems like you're getting a bill from this person, that person, the other person. Is there an effort at some of these places to consolidate it? I mean, I'm assuming perhaps at Kaiser Permanente, for example, it's it's a combined thing. But when you're in a dispersed hospital system, it seems that every department or every clinician group is going to have their own billing.
So that's a good question you rose up. The billing is a very complicated matter. There's a lot of payers that have to adjust, not only they have to adjust their guidelines along with the physicians. And so the process has been a little bit complicated for that. But what I can say is that by having it shift to an organization metrics, there are incentives that have also been paid so that if a service is now requiring them to be included on the team for a patient and then they're billed for the service, there is a payer reimbursement for the entire service, and there's also rewards based on the outcome as well. It's a very complicated matter, and to be honest, I'm not too sure about the literature about that. But you raise a good question because there is another service that is now suddenly involved in the patient's healthcare, and the reimbursement for that, it could be more, it could be less, but overall less. That's the cost benefit behind it. I hope that answered your question.
Dr. Neeson?
Thanks. So first of all, thank you for looking at this issue. This is a really timely issue in healthcare in general, and will play a major role, I think, in the delivery of care during your medical school or your medical career,
Right.
quite honestly. So when did you look at anything? Was there any literature on the accountable care organizations and what used to initially be called the triple aim, which is now the quadruple aim, where you have from the Institute for Healthcare Research, Don Berwick and his group, where you have better care for the patient, lower overall cost, improved satisfaction from the patient, and improve satisfaction on the part of the physician. That was actually the fourth of what was the triple aim. All of a sudden they decided, you know, physicians are getting burned out. Maybe we need to look at physician satisfaction too. So, but it does put the financial risk more on the clinicians instead of the patient. So did you see anything on either of those two issues, the accountable care organizations and the triple or quadruple aim?
In fact, I did, Dr. Neeson, thank you for the question. I did found that the analysis of our paper mentioned not only the successes, but the challenges. And in that they mentioned the challenge that the star rating, like if we identified the gaps, and we identified it very effectively with a strong EHR, a GIC team, that makes a lot of sense, right? But why were only 63% of identified gaps covered? And when I looked more into analysis of it, I found that through what Dr. Wolf was mentioning as well, there's a lot of patient adherence problems. There's a lot of physician satisfaction problems. It's not a complete 100% value-based care. And so, and when I read more of the limitations behind the study, they said that a lot of the limitations were that there was provider satisfaction that mentioned that there was overall, it was average, is what, in a nutshell, I'll say it that way. And so it kind of raised the question, so why only 63%? You have the gaps, it's right in front of you. It's also actionable because it's met by the measurement standard. And so it brings up a question that, yeah, patients, you know, they have different satisfaction rates. They have the physician as well, the patient. This study particularly was done on the triple aim model. And so the quadruple aim model is probably a more recent model.
Mm-hmm. Yeah. Thank you. Thank you. I think this is just a terrific issue. And I think your point about health literacy is really critical. You know, what we're seeing from the Medicare Advantage groups is they are cherry picking the healthy elders. So those elders who have higher health literacy to be enrolled in their Medicare Advantage plans, while the dual eligibles, the lower income patient population who are over 65, who may have both Medicaid and Medicare, will have less health literacy and may not understand the importance of that colonoscopy or that mammography, all of the points that you made. So it's harder in that population, maybe you're going to have to focus a lot more on health education, as you pointed out. So
you make a fantastic point, and it's unfortunate because I do anticipate changes coming behind that, because now that it's moving towards a patient-centered model, like I mentioned earlier, there's social determinants that are now taken into play. There's
yes, yeah,
there's
absolutely.
barriers to entry, healthcare literacy, and that alone I feel can solve almost half, maybe more, of the problems that we face today. And so it's going to be a process, because there's a lot of different opinions, a lot of ways people like to go about it, but I do anticipate changes coming for that.
Nicely done. Nicely done.
Thank you, Dr. Newsom.
Any other questions, comments? Well, if not, just reiterate again, excellent job, super articulate and nicely done. Thank you so much again for participating and presenting for us today. And thank you everyone that was here.
Thank you, Anne Marie. Thank you everybody else for coming. I appreciate this a lot.